you've heard about the really excellent results of the anti-NECTIN4 antibody drug conjugate enfortumab vedotin for treatment of metastatic urothelial cancer patients. And so far, we had no predictive biomarkers available to really predict response to this new type of targeted therapy for metastatic urothelial cancer patients. And in the study we've just recently published at JCO, we were able to really demonstrate a remarkable biomarker signal for the biomarker NECTIN4 amplification to predict anti-NECTIN4 antibody drug conjugate therapy response. So basically, we know that from other ADCs, such as HER2 ADCs, that ADC response is correlated with the target gene expression. But this has not been described for the enfortumab vedotin context within the clinical trials, as the community was so far thinking that basically all urothelial cancer patients express NECTIN4 to a high magnitude. We have described last year in clinical cancer research that a substantial proportion of patients has a loss or decrease of membranous NECTIN4 expression, which is needed for binding of enfortumab vedotin throughout metastatic spread, and demonstrated that membranous NECTIN4 expression is correlated with EV response. In the current study, we were looking at NECTIN4 copy number alteration. And excitingly, the NECTIN4 amplification is one of the most frequently occurring copy number alteration in urothelial cancers, with about 25 to 30% in frequency. And in this study, we were able to demonstrate that this 25 to 30% of patients with NECTIN4 amplification really have favorable outcomes on EV single agent therapy. These patients have very high membranous NECTIN4 expression also throughout metastatic evolution. And we were able to show that more than 90% of the patients with an amplification had an objective response rate to single agent EV therapy, which is really a remarkable biomarker signal. And this translates also in prolonged progression-free and overall survival. The median progression-free survival in the NECTIN4 amplified EV-treated population was more than 16 months, and median overall survival was not reached, with a 12-month survival rate of about 90%, compared to only 41% in the NECTIN4 non-amplified population. We were able to establish an easy and straightforward NECTIN4 FISH assay with a probe which is customly available. So in the standard of care setting and molecular pathology setting, there are a couple of multiple FISH assays available for clinical routine, like HER2 FISH assays. But we were the first now to really establish a specific NECTIN4 FISH for tumoral testing, and we're able to demonstrate that identification of NECTIN4 amplification using FISH is robust, and we were able to validate the FISH also on using NGS and other microarray tests to really demonstrate the FISH assay we've established is robust and specific. And in our cohort of more than 100 patients treated with EV, we were then able to demonstrate that around 25% of the patients had a NECTIN4 amplification with the really strong biomarker signal I've just mentioned in the last question. In terms of clinical implementation, FISH assays would be the easiest to really implement into standard of care, because FISH assays are straightforward assays, quite quite cheap and easy to implement also in smaller molecular pathology labs. So we believe that a FISH assay would be the best way to really identify Nectin-4 amplification, and is less expensive than, for example, NGS-based diagnostics of copy number alterations. So the main limitation of our study is certainly that the cohort we've assembled is a retrospective cohort. We're currently establishing a prospective validation cohort to also validate the biomarker signal in a prospectively assembled cohort. But this is the retrospective nature of our study is the major limitation. Another limitation could be that we've integrated both primary urothelial cancer samples and metastatic samples, because in the majority of patients, no metastatic biopsied samples were available. But we believe that this is not a major limitation, but we've also demonstrated in a small sub-cohort of our study cohort, where we had both primary and matched metastatic sample, that the Nectin-4 copy number status is quite robust throughout metastatic evolution, with more than 90% of the primary tumors retaining the Nectin-4 copy number alteration also in the metastatic stage. But for sure, the most significant limitation is the retrospective nature. And we hope that other groups and also we with our prospective validation cohort can validate this finding. And we are also currently in the process of assembling a cohort of patients treated with EV pembrolizumab to also assess whether this biomarker is also of relevance for the combination setting. And we believe that this might be the case because we know that EV has the higher single agent activity than pembrolizumab. So we believe that this biomarker could also be of particular relevance for the combination EV pembrolizumab, and hypothesize that probably patients with Nectin-4 amplification are overrepresented in the complete response population we've seen in the EV302 phase 3 trial. We've also demonstrated in our publication that Nectin-4 amplification seems to be really a frequently occurring genomic alteration throughout solid cancers. It's also frequently observed in lung cancer, breast cancer, also other disease types. So we believe that this biomarker could also be an interesting biomarker for this disease types, where also currently Nectin-4 targeting drugs like enfortumab vedotin are in clinical testing, but we don't have data so far on this. But it would be really exciting to see whether this biomarker can also drive a rational Nectin-4 targeting drug development in diseases beyond urothelial cancer.